FMG.
Hello. Actually, ma'am, this is not in presentation
Yeah,
mode.
just a second.
Okay.
Is this better?
Yes, ma'am. Please continue.
Okay, thank you. Thank you. Okay, so let's begin with the session. First of all, a very good evening, everyone. It's an absolute pleasure to welcome all of you for this very special FMG Masterclass. With FMG exam just around the corner on 26th of July, I know the pressure is real, but so is your preparation, your potential, and your passion for medicine. Today's session is all about giving you the final boost, clarifying concepts, strengthening your strategy, and most importantly, reinforcing your confidence. My name is Bharti and I'll be the host for this webinar. We have curated today's class with one goal in mind, to help you cross that finish line with clarity and conviction. We have joined with one of our brilliant educator and expert who will walk you through this high-yield topics, last-minute tips and tricks, and more focused exam strategies. So let me just start with the presentation. So first, let me brief you about Academically. Headquartered in Australia, Academically is an edtech aimed at helping healthcare professionals to excel in their lives and their careers. It was established by Dr. Akram Ahmad, who is an educationist and a healthcare professional with years of experience across several roles in Australia, India, and Malaysia. Academically offers support to healthcare professionals who wish to upscale their careers by migrating to Australia other countries, settling new standards by providing preparation courses for more advanced global healthcare exams. Academically offers guidance, resources, and unwavering support. On your screen is our founder and CEO, Dr. Akram. Dr. Akram is an esteemed clinical pharmacist, distinguished professor, and accomplished research scientist with an impressive 15 years of teaching and research experience in India, Malaysia, and Australia. With a determination to help healthcare professionals across the globe achieve their dream of moving abroad, he started Academically. Through this initiative, he provides education and training for pharmacists, medical doctors, dentists, nurse, lab technicians, and physiotherapists for various medical registration exams so that they can move to their dream country. To further support the career advancement of healthcare professionals, he has now launched a study abroad program, those who wish to pursue higher education abroad. And I have a very interesting announcement here. So before he leaves back to Australia, as he is traveling to India since last few months, so we are arranging few, again, meetup sessions. So you can choose the destination which suits you the most. On 27th of July, we are keeping it in Dehradun. On 2nd of August, it's in Hyderabad. And finally, on 3rd of August, it's in Bangalore. So you can just, if you wish to, connect with Dr. Akram and get the tips and all the important details, you can just visit any of these three destinations. So on your screen, you can see our academic heads. Academically is well curated with the academic heads, Dr. Rini and Dr. Alok. I have with me Dr. Rini. She can just introduce herself and brief you about the.
So thank you, Bharti. A very good evening to all of you. Thank you so much for joining for the webinar. I know time is of most value here, but we at Academically are committed not only at providing coaching, but like mentoring the students in their healthcare journeys. So I'm sure you would benefit a lot from this session, and I wish you all the very best for your exam. Thank you.
Thank you, Dr. Rini. So on your screen, we have a team of very talented educators who themselves have gone through the same journey. And out of these, I have with me Dr. Amit Desai here. And I would like to request sir to join and introduce himself and carry it on from here. And apart from that, I would like to inform all of you, those who are joining for this session, like in the chat box, you can find the link that Academically has launched its free AI mock test for FMG students. So just make use of these opportunities. Just visit our website. The quiz is available. It's an AI generated mock test. So do attempt the same. And now over to Dr. Ahmed. I'll just unshare my screen. Sir, are you there? Just allow me a second. Faiz, can you just check the settings? I think Dr. Amit is facing some difficulties in switching on his camera and sharing the screen.
Sure, I'll just
In the
give me 1
meantime,
moment.
I'll just update you all, those who have joined for this webinar, that AI generated mock is available for all of you. So just visit our website and just make use of these opportunities. Apart from that, as I have updated you all, that we are keeping meetup sessions, 3 sessions back to back. So whichever is convenient for you, you are advised to visit there and get the informative information from no other than Dr. Akram himself. And in the meantime, we are just checking. Dr. Amit will be joining us shortly.
Hello, everyone. Guys, so Dr. Amit sir will be giving you another high-yield topic on FMG. But apart from this FMG, if you have any other question, if you are looking for a plan B, like maybe Australian Medical Council exam, USMLE, PLAB, or anything about Australia, if you want to ask me, you can. Meanwhile, sir is joining soon. किसी कोई question, maybe you can just type in chat box so I can reply maybe. I know सबके exam से सालों को इतने pressure में they want to see the sir only. That's fine. But maybe once you give this exam, or if you want to know more about Australia or any other countries, you can connect us again.
Yes, so it's an FMG exam. Definitely, they have some pressure on them, but definitely we are there for you, and we really wish that you clear your FMG with flying colors. And do join us. And the mock that I've just updated you, you can just visit our website and make use of this advantage that you are getting.
Hi, Bharti ma'am. There won't be a problem now, I guess. Ask him to join.
See, I'm online with sir. He's not getting the permissions.
He can end the call and join again. He might be able to.
Sir, you
again.
Maybe here, guys, some issue in that technical. Just give it 2 more minutes. Sir is going to join very soon.
Yeah, so sir will be joining in a while, and these are the technical issues. No one is in control of this, so we are so sorry for this. But yes, he'll be joining us. So sir, someone is asking about AMC exam. How can we pass the exam? AMC.
I think Dr. One, you are focusing on FMG, right? You are going to write FMG. I hope you will pass this exam and become a doctor in India. But if you want to become a registered doctor in Australia, or you want to do PG in Australia, so in that case, you need to pass this AMC exam. Australian medical exam के 2 parts हैं, part 1 and part 2, and academically provide basically live classes from Australia. So we have Indian faculty. They are now practicing in Australia. Okay, so they provide live classes, study material. So you need to go here and there. We will complete the entire process, like your documentation process for AMC classes, AMC 1 classes, AMC 2 classes. We also provide classes for English test, and once you pass this, and you can practice in Australia. And in Australia, the good thing is here you can work after part 1. Dr. Amit sir already is here, so he will take the from here, and I will take your questions once we finish this session. And Fasil Khan, welcome salam, and good evening. I'm example intention. Yes, so you must pass your degree, and in degree at least 1 year experience. I mean, this internship is mandatory. Are to sit in the exam. यस, ऑस्ट्रेलिया में जो भी इंटर्नशिप होगा वो पेड होगा. आफ्टर AMC1 के बाद में जॉब होता है जूनियर मेडिकल ऑफिसर या रेजिडेंट मेडिकल ऑफिसर का जो जॉब है वो पेड जॉब है, उसमें आपको सैलरी मिलता है. So around 4 to 5 lakh Indian rupees per month, I can say minimum you will get.
So I think we can see sir now. Good evening, Dr. Ahmed.
Good evening. Are you all able to see me?
Yes,
Yes.
good evening, Dr. Amit.
Yeah. Good evening, sir. Good evening, everyone. Are you able to see my presentation?
Yes. Thank you.
Yes,
Oh, okay. So I am not able to see myself, but I am able to see my presentation. That is good enough. Okay. So I am Dr. Amit Desai. Hello. I am a surgeon by profession, and I'm also a postgraduate teacher. And as far as FMGE exam is concerned, I've been teaching FMGE students for last 10 years now, since 2015. So in 10 years, I've got a lot of experience, and I just want to share a bit of it with you all. So can I start?
yes,
Sure,
sir.
sir.
All right. So let us look at carcinoma of breast. Now, if you look at your FMGE exams, you will realize that a lot of questions are asked on surgery. All right. Nowadays, they ask you a lot of clinical based scenarios also. And out of surgery, if you ask me one topic, which is really, really very high yielding or important, that would be breast. All right. Now, amongst breast also, breast itself is divided into two important parts. One is breast cancer and the other one is the benign breast diseases. All right. So today I'll be talking about breast cancer, because out of these two also, breast cancer, a lot of questions are asked, and it is really worthwhile to know this topic and also be really expert at it. So just a brief introduction, that breast, as we know, it extends from the second to the sixth rib. All right, again from the sternal edge to the mid axillary line. Now we also know that a part of the breast goes towards the axilla, and it is called as the axillary tail of Spence. What is the importance? There are two importances. One is there can be a cancer sometimes over here, and we may not be able to realize it because it is in the axilla. Second thing is that there might be a hypertrophied axillary tail of Spence, and the importance of this hypertrophy is that for cosmetic reasons sometimes we will have to remove it. Okay, so these are the two important points that we must remember as far as axillary tail of Spence is concerned. Now there is another space that we must know, and that is known as the submammary space. Now what is this space? It is the space between the breast and the deep fascia. Now why is this important? This is important because when this space is free, when a lady bends forward, the breasts can fall forward. All right. Now, in cancer, if this space is invaded, then you will realize that when you make the lady bend forward, that particular breast is not falling forward. This is an important test that you must have done during your clinical examination. If you remember, many times we say in clinical examination that both breasts are falling forward equally, or one breast is not falling forward that much. All right. So this is to know whether this submammary space is invaded or not. Second importance of the submammary space is that in tuberculosis, sometimes there can be pus formation over there. So these are the two important points that you need to remember. Now, when we look at the structure of the breast in general, we look at something called as duct and lobular unit. Okay, we look at something called as a duct and lobular unit, terminal duct and lobular unit. Now, out of these two are important, duct and lobular. Why? For the simple reason that the pathologies might be ductal or lobular. So there might be ductal carcinoma in situ.
Dr. Amit,
Yes.
your screen is not visible now.
Screen is not visible.
No, I think someone else has pinned it.
So what can be? So do I stop sharing and reshare it?
Yes, sir, we can try that.
There's somebody called Dr. Nadeem who has taken over. So I'll take it over now from there. Can you make the setting in such a way that only I will be the presenter?
Actually, you don't have the host control right now.
I don't think so.
Yeah. Working now.
Okay, working, right?
Yeah, yeah. Just share it full screen.
Yeah, yeah. All right. So there is ductal carcinoma in situ, lobular carcinoma in situ. Similarly, there will be invasive ductal carcinoma, invasive lobular carcinoma. Okay, what are the peculiarities of each we will be studying, but this is what we need to remember basically. So there are going to be ducts and lobules, and this is going to form what is known as the glandular tissue. Now, this glandular tissue, in between them is the connective tissue stroma. And this is what is going to form the lobe, and multiple lobes together will be called as the breast. Now, one important thing about this is that, of course, nothing related to malignancy, but whenever you come across the cases of breast abscess, please remember that breast abscess affects the stroma, whereas the milk secretion is done by the glandular tissue. And so very often this question is asked, or even in the practical, in the Viva, they will ask you that if a lady has undergone incision and drainage for breast abscess, would you allow her to breastfeed? The answer is yes. And what is the logic? The logic is that in breast abscess, the infection is in the stroma, whereas the milk is secreted by the glandular tissue. So you can continue breast feeding. Then there are something called as 𝗙𝗪𝗂𝗄𝗏's ligaments. Okay, they run from the clavicle and they go through the breast tissue to the skin. Okay, dermis of the skin. So if this is the breast leg, this will move in this direction. They are minute ligaments, all right? And the importance of these 𝗙𝗪𝗂𝗏 ligaments is that at times in malignancy, even they may be infiltrated. Now, when they get infiltrated, what happens? We will be studying in some time from now. But these are certain important small points about breast. If you look at the arterial supply, just for the sake of it, axillary, internal thoracic, and second to fourth intercostal arteries. These are called as the perforating branches. These are called as the perforators or the perforator branches. All right. Now, this is what is really important for us, lymphatic drainage. And lymphatic drainage, when we see, there are two important things that we have to see. One is the lymphatics, that is the lymphatic vessels, and the other are the lymph nodes. Now, if you look at the breast, these lymphatic vessels are divided into the superficial and the deep lymphatics. These are the vessels which carry the lymph, all right? So these deep lymphatics will drain the parenchyma, whereas the superficial lymphatics will drain the skin, all right? Except for the nipple areola region, which will again go into the deep lymphatics, all right? Now, one important characteristics about these lymphatics is that there is a plexus. What do you mean by plexus? There is intermingling of these lymphatics, and this is called as subareolar plexus of Sappi. All right, and that is the reason why, even though there might be a cancer in one part of the breast, yet this cancer can spread to various types of lymph nodes. Why? Because there is a plexus, there is an interconnection of lymphatics, and breast lymphatics do not contain valves. Now, this was the basic information. Now, let us look at the real high yield information on which questions are going to be asked. So, where does the lymph of the breast drain? So, 75% of the lymph goes to axillary group of lymph nodes. All right. 20% will go to the internal mammary, and the rest of the lymph will go to all these other nodes. Now, axillary, when you see, if you have examined the patient of breast cancer, you know that there are anterior axillary lymph nodes which are along the pectoralis major muscle. Why along pectoralis major? Because that forms the anterior border of the axilla. Then there are posterior axillary lymph nodes which are along the latissimus dorsi muscle. Why latissimus dorsi? Because it forms the posterior border of the axilla. There are central nodes which are along the medial border. And what is forming the medial border? It is the chest wall or the ribs. So that forms the medial border. Now think about it. What is it that is going to form the lateral border? So the lateral border, if you want to know what is going to form, think about the axilla like a prism. Suppose if you are holding a prism over here, the anterior edge of the prism is along pectoralis major. The posterior edge of the prism is along the latissimus dorsi. The medial part is touching the chest wall. Now, if you're going to put your hand over the prism, what is going to lie along the lateral wall? It is the humerus bone, okay, or the arm. So lateral nodes are along the humerus bone. And then there are certain nodes at the top, at the apex. They are called as the apical nodes. This is important because when you are doing surgery, you need to remove all these. Then there are internal mammary lymph nodes which are intrathoracic, along the internal mammary artery. You know that internal mammary arteries are the arteries which are used for bypass surgery. All right, so along internal mammary arteries. And there are these other lymph nodes, of which supraclavicular lymph nodes are important because they are high up. All right. Now, if you look at the drainage, the lymph initially goes to the anterior and the posterior group. From there, it goes to the central and the lateral group. From there, it goes to the apical group. And from there, it will go to the supraclavicular group of lymph nodes. Now, if you are reading any textbook of oncology, you will tell me that, sir, you are telling me anterior group, posterior group, central group, lateral group, apical group. But none of my textbooks talk about it. My oncology textbooks call it as level 1, level 2, and level 3. So what auxiliary group are you talking about? So let us see what is level 1, what is level 2, and what is level 3. All right. This we have already done. 75% of the lymph goes to the axillary. So what is level 1, level 2, and level 3? So for that, we have to know the location of a muscle called as pectoralis minor muscle. Pectoralis minor, not major, but minor, which is behind the major. All right. All those lymph nodes which are behind this pectoralis minor are called as level 2 lymph nodes. Okay. Now, suppose if this is the lateral part and this is the medial part, that means this is the left side of the patient. All those which are behind the pectoralis minor are called as level 2. Now, what is level 1? Everything that is lateral is level 1 and everything that is medial is level 3. Okay, level 1, level 2, level 3. So now, what did we study? Anterior group, posterior group, lateral group, central group, apical group. Now, where do these fall? So let us look at this. When we say level 1, they are the anterior, posterior, and the lateral group. When we talk about level 2, they are the central group and the group between the two pectorals. Okay, that is the pectoralis major and minor. This is called as interpectoral lymph nodes of Rotor. Rotor was the person who described it. So they stand between the two pectoral muscles. And level 3 are the apical group of lymph nodes. So from now onwards, when we will talk about lymph nodes and lymph node dissection, we will talk level 1, level 2, level 3. Okay, so please remember what we are actually talking about. Now, let us look at the risk factors. So first and foremost, the important risk factor is the family history. Now, family history of what? So, family history of breast cancer. Breast cancer on the mother's side. So, breast cancer for the mother, breast cancer in the aunt, breast cancer in the grandmother from the mother's side. Apart from that, ovarian cancer. Apart from that, colon cancer. And from the father's side, prostate cancer. Okay, so don't just ask for breast cancer, ask for these also, because they are all related to two important genes, okay, which we will be studying in some time, and those are called as BRCA genes, BRCA1, BRCA2 genes. All right, so these are the group of cancers which are related to them. Apart from that, what else are the risk factors? So we've made a small mnemonic for you. Okay, so other one is contraceptive, oral contraceptive pills, especially those which have got high estrogen. Remember, breast cancer is an estrogen dependent cancer. So every time there is extra estrogen in the body, this will promote the cancer. Age. So as the age advances, the chances for cancer increase. All right. Females are much more affected than males. The ratio is 99:1, which means that in a high volume center, if you see 100 patients, 1 will be male and 99 will be female. Okay, so it also means that breast cancer is not exclusively in females, also in males. Then hormone replacement therapy. Many times we start hormone replacement therapy to prevent osteoporosis. Now, when you have taken it for more than 10 years, when a lady has taken it for more than 10 years, this becomes a risk factor for breast cancer. Now, what are the protective factors? So, pregnancy is a protective factor. Why is pregnancy protective factor? Because we said that breast cancer is an estrogen dependent cancer. So, that monthly cycle of estrogen that is there, that is broken in pregnancy. So pregnancy is a protective factor, and more importantly, age at first pregnancy. So if there is the early age at first pregnancy, that becomes a protective factor. Because when the menarche starts, if within a few years, if the first pregnancy is there, that means that cycle is broken early on. Instead, if a lady gets pregnant at 42, 43, it takes a long time before the cycle is broken, so it is not as protective. Lactation is again protective because what is high in lactation? Prolactin is high. And if you have studied endocrinology, you know that prolactin inhibits GnRH. And because GnRH is inhibited, again, estrogen, progesterone are low, and that is why this is protective. Then menopause. Now, in menopause, what happens is, see, there are 3 types of estrogen. Let me write somewhere over here. 3 types of estrogen. What are the 3 types of estrogen? So there is one called as estradiol. The other type is estriol. Again, gynec and physiology you must have studied. And the third one is estrone. Where do we get estradiol? In ladies of reproductive age. And who produces it? It's the ovary. Granulosa theca cells, they are the ones which produce. Estriol, you see in ladies who are pregnant. And who produces it? It is the placenta which produces. Whereas estrone is seen in ladies who are menopausal. And who produces this? This one is produced by the fat, adipose tissue. So during menopause, what happens is that this estradiol stops forming and this takes over. And because of that, there is a small time period when the amount of estrogen is low. Estradiol is stopping and estrone has still not come up. Okay. So if you see, if you draw a graph, okay, of age versus incidence of breast cancer. What we were expecting, we said that as the age increases, the chances of breast cancer increase. But actually, this is not what happens. What happens is that up to a certain limit, this is what you see. And at menopause, there is a small plateau. And again, there is a rise. Why is this plateau? This is because change in the estrogen. And this is what is called as Clemenson's hook. It looks like a hook. So where is that hook? That hook is on the graph. Okay. So sometimes they might ask you this question: what is Clemenson's hook? So this is what you mean by that. Now, another important risk factor is benign breast disease. All right. So which are the benign breast diseases which increase the chance? So when there is hyperplasia. When there is hyperplasia, there is increase in the chance of breast cancer. Now, if this hyperplasia is atypical, there is a fourfold increase. Okay, if there is just a hyperplasia, 2 times increase in the chance of breast cancer. But if it is atypical, it is 4 times. And again, as I said, atypical can be ductal or lobular. And if this atypical ductal hyperplasia, it involves the duct system, then there is 7-fold increase. All right. So this is what you need to remember. Apart from that, all the other benign diseases will not increase the chance. So you have to look out for 3 important keywords. One is hyperplasia, second is atypical, and third is ductal involvement. Accordingly, the relative risk will increase. Now let us look at the genetics. Okay. So if you see all the patients of breast cancer, if you are a high volume center, you will realize that around 65 to 75% of the patients that are coming to your hospital are sporadic. That means they just developed breast cancer. There was no genetic predisposition. If you look at the others, around 20 to 30% of them will have some gene which will be inciting, but that gene will not be associated with any syndrome. So this is called as familial. Familial means what? Gene is present, but syndrome is absent. There is no syndrome. And lastly, you will have a hereditary breast cancer. Here, what do you see in 5 to 10% of the patients? That there will be a gene, and this gene will also be associated with some syndrome. In a particular way, that gene is born. Now, out of these 5 to 10%, if you take a breakdown, the commonest gene is BRCA1. Almost in 45% of these hereditary cancers, you will see BRCA1 gene. In around 35% of hereditary cancers, you will see BRCA2 gene. In 1% cancers, you will see P53. And apart from that, there are other syndromes which cause less than 1% of hereditary cancers. Okay. Remember, only 10% cancers are hereditary, and out of those 10% also, only 45% are BRCA1. So if you are asked a question in your exam that which is the most common gene associated with breast cancer, it is BRCA1. Okay, this is an exam question. This is an exam question. This has been asked, okay, which is the most common gene associated with breast cancer? BRCA1. Apart from that, you have Cowden's syndrome, Lee-Fraumenis, that is P53. There is another one called as ataxia-telangiectasia. There is something called as Muir-Torr syndrome, and there is Peutz-Jeghers syndrome. So if you want, you can remember it with the mnemonic of CLAMP. Very, very rarely they will ask this question. That is why you need to remember only 3: BRCA1, BRCA2, and P53. Any other syndrome that they give will cause less than 1% of the cancer. So sometimes they might ask you which is the least common cause of breast cancer. So any option, option D, which is there, apart from these 3, that will be your answer. They can either give you Cowden's, they can either give you Peutz-Jeghers, they can give you ataxia-telangiectasia, whatever. All right. Where is BRCA1 gene located? Okay. Where is BRCA1 gene located? Let us look at BRCA1 and 2. All right. So the next question is, where is BRCA2 located? Let us see. So BRCA1 is located on chromosome number 17, whereas BRCA2 is located on chromosome number 30. All right. Now, what kind of tumors is BRCA1 associated with? So it is associated with breast cancer, ovarian cancer, then colon cancer, and also prostate cancer. Just now, which we saw in a family history. If you look at BRCA2, it is also associated with breast cancer. It is also associated with ovarian cancer. It is also associated with colon and prostate. But apart from that, it is also associated with pancreas cancer. It is also associated with gallbladder cancer. It is also associated with stomach cancer. And it is also associated with melanoma. Not only that, this is also associated with male breast cancer. So in the exam, if a question is asked to you, which is the gene which is associated, which is that gene which is associated with male breast cancer, then your answer is BRCA2. Okay. So just looking at these 2 points, you will feel that BRCA1 is better than BRCA2. But remember, BRCA1 gives rise to poorly differentiated cancers. And usually the hormone receptors are negative. In breast cancer, if the hormone receptors are positive, it is a good sign or good prognosis. Okay, so in BRCA2, there are well-differentiated tumors with positive hormone receptors. What are the hormone receptors? ER, that is estrogen receptor, and PR, that is progesterone receptor. Okay, so this is the importance. This is the difference between the two. Now let us look at screening for breast cancer. All right. Now, first question is, who should be screened? All right, who should be screened? So there are various guidelines. In India, we follow the NCCA guidelines, which say that if a lady has a normal risk of breast cancer, then she should start screening at 40 years. If a lady has high risk for breast cancer, she should start at 25 years. Now, till what age should this should be done? So it should be done till 74 years of age. Beyond 74 years of age, screening has no big value. Okay, so this is important. Now, the next question is, how frequently should we screen? And before that, how should we screen? All right, we said that normal risk start at 40, high risk start at 25. But how should we do the screening? So for a normal risk, we will do a mammography. What do you mean by mammography? It is X-ray mammography plus sonomammography. Okay, whereas this is for normal risk. And if there is a high risk patient, then we will do an MRI. So how will you screen a high risk woman? With MRI, and a normal risk woman with mammography. How frequently? So between 40 to 50 years, you will do mammography once a year. And from 50 years onwards, you will do once every 2 years. Okay, once in every 2 years. MRI is usually done yearly because they are high risk patients. All right, what is the advantage of screening? You will have 30% reduction in mortality. All right. Now we go to another thing called as triple assessment. When will you do triple assessment? So whenever you want to diagnose a case of breast lump, or rather any complaint of breast, okay, but more importantly, breast lump. Triple assessment means what? 3 things you will do. What you will do? 1, you will do clinical exam. Then the other thing that you will do is radiological examination. And the third thing that you will do is the pathological examination. Radiological examination usually includes mammography, or ultrasonography. Sometimes MRI, but mostly mammography and USG. Pathological includes FNAC, or better still, a true cut biopsy. So in this, which is the answer? This becomes the answer. Clinical examination, mammography, and FNAC. Question is, when will you do clinical examination? The best time to do clinical examination is 7th day post menses. Why? Because that is the time when the breast is least nodular. Okay, this is a question which has been asked to you 15 years ago. For 15 years, they haven't asked this question, but 15 years ago, they used to ask you a question in FMGE that on what day will you preferably do clinical examination? So 7th day post menses. That is the answer. Okay, this is an exam question. Not been asked for many years, but this can be asked. Okay. Now, as I said, clinical, imaging, and pathological. Okay. Why do we do it? Because the accuracy of diagnosing a lesion is almost 100%. It is 99.9% accuracy, which is almost 100% accuracy. So if you do these three things, almost 100% of the times you will come to an accurate diagnosis. All right. So when you are doing the pathology, there are three types of things that you can do. Fine needle aspiration cytology. The importance of this is that you can do a cytological grading. Okay, that is the advantage of this. But what is the disadvantage? Disadvantage is that you cannot do hormone receptors. ER/PR status you cannot do, which is a major disadvantage. And also there is something called as HER2/neu, which you cannot do. Now, these three things are very important because these tell us the molecular grading of a breast cancer. So, better still is to do a true cut biopsy, which will show you all these things. Only thing is, true cut biopsy is a slightly bigger and slightly more painful. Or you can do excision biopsy. Now, when you do a biopsy and send it to a pathologist, the pathologist will use what is known as modified Bloom-Richardson scoring of the tumor. What are the three things that a pathologist will see? Tubule formation, polymorphism, and mitotic index. And based on this, they will give you modified Bloom-Richardson scoring. All right. So that is important. Because if the Bloom-Richardson scoring is not very good, then that becomes an indication for chemotherapy and radiotherapy. All right. That's it. As we said, what is the advantage of FNAC? Pathological grading is possible. Another problem is it cannot differentiate between in situ and invasive cancer. Now, what do we mean by in situ cancer? In situ cancer is when the cells are dysplastic. The cells are abnormal, but the basement membrane is intact. The basement membrane is intact. This is what we mean by in situ cancer. The moment the basement membrane breaks down, we call it as invasive cancer. All right. And in breast, we will be talking, there are three types of in situ cancers. One, of course, is the ductal carcinoma in situ. The other one is the lobular carcinoma in situ. And the third one is the Paget's disease. All right. These are the three types of in situ cancers in breast. Now, let us go to the imaging and let us go to mammography. There are basically two types of mammography. One is screening mammography and one is diagnostic mammography. Now, what is the difference between the two? The difference is that when a lady does not have any symptoms, okay, when the lady does not have any symptoms related to breast, and yet she goes for mammography, it is called a screening mammography. She can keep it with her so that next time when she does a mammography, she can show the doctor and they can find out the difference between the two. Okay, so that is called a screening. What is diagnostic mammography? When a lady has a lump or some lesion of the breast, and that is the time when she does mammography, it is called as diagnostic mammography. When is mammography done? More than 35 years of age. Now you will ask me, what if the lady is below 35 years of age? Then you will do a sonography, that is sonomammography. Only sonography, not X-ray. You will ask me why you will do that. That is because the breasts in younger female are denser. So you are unlikely to be able to diagnose or pick up lesions on X-ray mammography. That is why sonography is better, all right, because breast is denser, all right. Now, this is an important question. How much exposure are we subjecting the lady to? So it is 0.1 centigrade. This is an exam question, okay? You must remember, this is an exam question. Question can be asked. What is the exposure in mammography? 0.1 centigrade. Now, when you do a mammography, suppose if this is the breast, there are two views that you take. One is this, okay? You take an X-ray in this direction. This is known as medial lateral oblique, which gives you most of the breast tissue. And then there is one which is taken like this. You compress the breast and take it, which is called as craniocaudal, CC or craniocaudal. Okay, these are the two views that you will take. So if you see the craniocaudal view, it is like this. Okay, one side is medial, one side is lateral. Okay, and then you also have the medial lateral oblique view, which is usually looking like this, which looks oblong. All right. Medial lateral oblique view gives you the most of the area of the breast, especially outer quadrant, upper outer quadrant. Now, when you have done a mammography and when the X-rays come to you, what will you look for? You will broadly look for two things. One is the density abnormalities and second is the calcification. If you see some kinds of density, can you see there are these two densities which are different from the rest of the breast? How do these look? According to that, you can predict whether they are benign or malignant. And if there is calcification, what type of calcification is there? That can tell you whether it is likely to be benign or malignant. So benign lump, it will have a smooth margin. It will not be very dense, low density, homogeneous, and halo is because of edema. So there will be a thin halo around it. Okay, halo is seen nicely by the radiologist who is used to it. Whereas if you see a malignant tumor, it will have an ill-defined margin, spiculated. Okay, sometimes there might be one of the margins might just go to one end. That is called as comet tail appearance. It will be inhomogeneous. So some areas will be high density, some areas will be low density, and there will be a lot of edema. Okay, lot of edema, and so there'll be a wide halo. If you look at the calcifications, benign will show you macro calcifications. That means large calcifications, more than 5 mm. So there is a benign tumor called as fibroadenoma. Now this fibroadenoma, if you see, it will show you something called as popcorn calcification. So the calcification looks as if there is a popcorn over here. Again, this is an exam question. Popcorn calcification is seen in, okay? So fibroadenoma. Whereas if you see the malignancy, the calcifications will be very thin, micro calcifications. All right. So this is another differentiating point. Now, apart from that, there are other things, okay? Like there might be distortion of architecture, retraction of nipple, thickening of skin, etc. All right. But these are all secondary. The two important things is the mass. How is the architecture of the mass? And secondly, calcification. Now, once you have done a mammography, the radiologist will report it based on a system called as breast imaging reporting and data system, which is called as BIRADS. Now, similarly, instead of breast, if you use thyroid, a similar system is used and it is called as TIRADS. Instead of thyroid, if you write prostate, then a similar system is used, which is called as PIRADS. Instead of prostate, if you write liver, then a similar system is used called as LIRADS. Okay, so breast imaging reporting is called as BIRADS, thyroid imaging reporting TIRADS, prostate imaging reporting PIRADS, liver imaging reporting is called as hello. Yeah. So these are the various categories. Remember that which is the one which is suggestive of malignancy? Type 5. Okay. Type 1 is benign. So what is 0? 0 is when you could not do a proper mammogram. You again have to do it because of some reason. And what is type 6? Type 6 is when the biopsy has already shown you that there is a malignancy, yet you are doing a mammogram. Now you will ask me the question, sir, if the biopsy is already showing you malignancy, why do you have to go and do a mammogram? So the answer lies in the next. Hello? So the answer lies in the next slide. These are the two things, okay? Multicentric and multifocal cancers. Now, what do we mean by multicentric and multifocal? Let us imagine that these are two breasts, okay? And there is a breast cancer over here, biopsy proven cancer. This is the primary. This is a biopsy proven cancer, and this is the primary. You do a mammogram and you find that there is another malignancy or another this over there, malignancy or a tumor over there. This is the secondary. You find that there is another tumor over here. This is the secondary. Now, what is the difference between these two? See, this is the one which is present in the same quadrant, whereas this is the one which is present in a different quadrant. So the one which is present in the same quadrant is called as multifocal, whereas the one which is present in the different quadrant is called as the multicentric. Why is this important? Because later on we will study that there is one type of surgery which is called as breast conservative surgery. So in breast conservative surgery, what happens is that we can just remove this quadrant and give radiotherapy. Okay, so this is the reason why it is important for us to know how far it has spread. Let us look at this question. Gold standard investigation for screening of patients of breast cancer in patients with breast implants, those ladies who have put breast implants. And if you are suspecting breast cancer, which is the best investigation? The answer is MRI. Okay, so let us just recapitulate. For women who are less than 35 years, the best is USG. All right. In women who have implants, the best is MRI. Secondly, if you are dealing with a lobular cancer, or if you are dealing with a lobular carcinoma in situ, then also the best one is MRI. Thirdly, we also saw that for screening of high risk ladies, MRI is the best. When will you do PET scan? PET scan you will do for recurrences in scarred breast. You have done surgery and now you feel that there is a recurrence. What will you do? You will do a PET scan. Okay. You will do a PET scan, and PET scan uses fluorodeoxyglucose. PET scan uses fluorodeoxyglucose. Okay, we have already seen this question. What is the dose in mammography? It is 0.1 centigrade. Okay, important. Now let us come to clinical features. The most common clinical feature is breast lump. Okay, exam question. Now you feel that it's a very silly question, but still it's been asked in the exam. Most common is breast lump. Breast pain is very late. Nipple discharge might be there. What type of discharge you will get? Blood stained discharge or serous discharge. That is the type of discharge that one gets. Nipple retraction might be seen, and ulceration of the skin or the nipple might also be seen, right? So now, dimpling in carcinoma breast is due to, as I said, it is due to, dimpling is due to Cooper's ligament involvement. Okay. Teethering. Teethering. What do we mean by teethering? Teethering means that if there is a lump, if this is a breast tissue, if there is a lump, and if you try to move this lump, after a certain point, you will get dimpling of the skin over here. Why will you get dimpling of the skin? Because the Cooper's ligament is involved. All right. This is called as teethering of the lump or dimpling of the skin. The lump is tethered and the skin becomes dimpled. Second is fixity. Fixity means what? If you try to pinch the skin and if the skin cannot be pinched, it is called as fixity. That means it indicates that skin is involved. Then there is something called as 𝗙𝗏𝗏 effect. What do you mean by that? The lymphatics of the skin, they get involved. Now, when the lymphatics get blocked, what happens? There is edema. Okay, and because of the edema, the skin swells. But the skin is not allowed to swell at places where the hair follicles are there. So if there are hair follicles like this, the skin is not allowed to swell like this or over there. So the skin swells in between and it is not allowed to swell at places where the hair follicle is there. So if you have seen persons who used to make mattresses earlier, they used to push all the cotton inside and then at places they used to take stitches. And if you see a new mattress, you will see that wherever the stitches are there, the mattress is down and otherwise the mattress is looking like a bumpy kind of a mattress. That is the kind of edema that you get. And when you look at that skin, it looks as if it's an orange peel. So look at that. This is the true orange peel. This is the true orange peel. And this is the 𝗙𝗏𝗏 appearance. Look at this. This is the 𝗙𝗏𝗏. Can you see the small? That is where the hair follicles are. Now the other one is cancer or curies. Can you see these nodules? These nodules are because of the infiltration of the or involvement of the lymphatics of the skin. Now here what happens? It is not the edema. There is actually growth of cells in the lymphatics, and that's why the small nodules are there. Okay, this is also called as armor coat appearance. Earlier, years ago, the soldiers used to go, they used to wear that armor coat that used to have such nodules on it. Okay, so armor coat appearance, also called as cancer or curies. Now let us see, where will you see the lump? The commonest place to get a lump is upper outer quadrant. Exam question. Second most common is the central area or the areolar region, and the least common is the lower inner quadrant. Okay, this is exam question. Now you will ask me why upper outer quadrant? Because most of the mass of the breast is located in the upper and outer quadrant. That's the reason. All right. These are three exam questions that are asked very often. Now let us go to carcinoma in situ. And what did I say for carcinoma in situ? That the cells are dysplastic, but basement membrane is intact. So the first type you will see is ductal carcinoma in situ. Now this is very often detected incidentally. You do an X-ray mammography and you will see areas of calcification on mammography. If you take microcalcification, okay, what kind of calcification? Microcalcification. If you take a biopsy, it will show you ductal carcinoma in situ. So what is the investigation of choice? Mammography. Treatment of choice is surgical excision. Why? Because this is pre-malignant. Now remember, all these questions all these statements are exam questions. All these are exam questions. Okay. So investigation of choice is mammography. Investigation of choice is mammography. All right. Treatment of choice is surgical excision with or without radiation. Now, how will you decide whether to give radiation or not? There is something called as Von-Neus prognostic index. Now see, okay, this is one lady. This is her right breast. This is her left breast. There is another lady whose right breast and left breast. Now this lady has a ductal carcinoma in situ over here. And this lady has a lobular carcinoma in situ over here. Now we said that ductal carcinoma in situ is a pre-malignant condition. So this lady will have an invasive ductal cancer over here only, on this place only, if you don't treat it. But lobular carcinoma in situ just makes a person susceptible to cancer. So the cancer can develop here, the cancer can develop here, the cancer can develop in the other breast also. Okay. So just because you have removed the lobular carcinoma in situ, it does not guarantee anything. So this is the difference between ductal carcinoma in situ and lobular carcinoma. So ductal carcinoma in situ, pre-malignant lesion, you have to do surgical excision, and then depending upon your Von-Neus prognostic index, you will decide whether to give radiation therapy or not. Whereas lobular carcinoma in situ can be multicentric, that means in multiple quadrants, and it can be bilateral. All right. Now the cells are arranged in a single line, so it is called as India file pattern. And one thing about the cells is that if there is excessive calcium in one cell, that cell will give the calcium to the next cell. It will not retain a lot of calcium. This is called as neighborhood calcification. So the moment excessive calcium builds up in one cell, it gives it to the other cell. So if you do an X-ray mammography, you will never be able to see calcification in this. Why? Because the calcium is distributed. Nobody is going to hoard that calcium. So the investigation of choice over here is MRI. Okay, all these are exam questions. All these are exam questions. I'm not using the red pen because it's getting stuck over there. All right. So now what we know, it can make the person, the ladies, susceptible for breast cancer, and breast cancer can be anywhere bilaterally. So how do we manage it? One of the ways is that if the lady is ready, we can do a bilateral mastectomy prophylactically before the cancer starts. But suppose if it's a younger lady, she says that I have not even gotten married. Why should I get operated? So in that case, you can give chemo prevention. You can give something called as aromatase inhibitors, like letrozole. Now, if the lady says that, no, I am not willing to take that also, or if you cannot give her due to some reason, then you just keep her under observation. Okay, whenever any lump develops, take a biopsy and treat accordingly. These people become high risk. Now, what are the other patterns? Infiltrative ductal carcinoma or invasive ductal carcinoma. This is the most common type. All right. Then infiltrating lobular carcinoma. What is the important part? Lobular carcinoma infiltrating is also multifocal and bilateral. It can be bilateral. So if they ask you a question, a lady has had cancer in one breast, and on the other side also you find a cancerous lesion. What type of cancer are you dealing with? So most probably you are dealing with lobular carcinoma. And medullary carcinoma is associated with BRCA1. Okay, it is soft and hemorrhagic, and BRCA1 it is associated with. Mucinous carcinoma you will see in elderly patient, and it's a bulky tumor with pools of mucin. So when you do a histopathology, you will see a lot of mucin over there. Papillary carcinoma has small papillae and multi-layered epithelium. Okay, and this is most important. Inflammatory carcinoma. What happens over here? There is subdermal lymphatics are involved and inflamed. So they look as if there is mastitis or breast abscess, okay? But actually it is cancer. It can be multifocal, it can be multicentric, it can also be bilateral. But for the exam, what is most important is that the cancer which has the worst prognosis is inflammatory carcinoma. If they can ask you what is the cancer with the worst prognosis, they can also ask you which is the cancer with the best prognosis. Answer is tubular carcinoma, almost 100%. Okay, so worst prognosis, inflammatory carcinoma. Best prognosis, tubular carcinoma. Then I was telling you about molecular classification. So in order to classify molecular classification, we use three things. One is estrogen receptor, second is progesterone receptor, and third is, as we said, HER2. Okay, HER2. Now, most of the times, ER and PR go hand in hand. All right, ER and PR go hand in hand. All right, that is there. So you have this luminal type A, which has the best prognosis, where the ER/PR is positive and HER2 is no. Now remember, ER/PR, if it is positive, it is good. But if HER2 is positive, it is bad. So this is a tumor where ER/PR is positive, HER2 is new, and this 𝐾I67 is also low. All right. In that case, you can give hormonal therapy. You can give hormonal therapy. All right. Now, this is again somewhat like luminal A. Okay, this is also somewhat like luminal A, normal like, but it is slightly worse prognosis. Again, you can give tamoxifen. Okay, don't bother about this one. Luminal B is where HER2 may be positive. All right, here also, because it is ER/PR positive, you can give hormonal therapy. Now, this is the third type, where ER/PR is low, negative, that is hormonal therapy is negative, but HER2 is positive. Now remember, when HER2 is positive, you can give a monoclonal antibody called Herceptin. Now Herceptin is a brand name. It is called as trastuzumab. Is called as trastuzumab. Okay, so that you can give. When ER/PR is positive, you will give hormonal therapy. What is hormonal therapy? We will see in some time, but hormonal therapy. So in these two types, ER/PR was positive. That's why we gave hormonal therapy. In this type, only HER2 is positive. So we are giving monoclonal antibody. And there might be a condition where all three are negative. This is called as triple negative. And here you have to give chemotherapy. Okay, which a high association with BRCA1. It has the worst prognosis and seen in younger women, and here you have to give chemotherapy. Okay, so this is the importance of triple negative. Out of these, this has the best prognosis, this has the worst prognosis. That is what you need to remember. Hasn't been asked in the exam, but very, very likely to be asked, because nowadays a lot of questions can be asked. Most common cause of death, again question exam, is pleural effusion because of metastasis. This can cause bone metastasis. Okay, bone metastasis. So which is the most common site for bone metastasis? It is the lumbar vertebra. Question can be asked. Second most common site is femur. All exam questions. So lumbar vertebra, please remember, lumbar vertebra, commonest site for bone metastasis. Okay, now, when we look at the management, there are a few questions that we need to answer. Let us see what these questions are. The first question that we are going to answer is, how do we treat the primary tumor? That's the first question that we will answer. Second question that we will answer is that how do we manage the axillary lymph nodes? This is the second question. Third question is, what is the role of other modalities? Now you will ask me, what do we mean by other modalities? So one of the other modalities is chemotherapy. One of the other modalities is radiotherapy. One of the other modalities is hormonal therapy. And one of the other and one of the other modalities is immunotherapy. So we are going to see what is the role of all these things. All right. So these are the three important questions that we are going to answer. Let us. So how do we manage primary tumor? You do it by surgical excision of tumor. Okay. Now, what kind of surgical excision that we do? There are various things, starting from the least invasive to the most invasive. The least invasive is just locally excise, wide local excision of the tumor. All right. So if suppose, let us look, suppose this is the breast. This is where the tumor is. Let's imagine. So you can start with a wide local excision. The other thing that you can do is you can remove an entire quadrant or an entire segment of breast. All right. The third thing that you can do is modified radical mastectomy, which we will be studying in detail because this is the most commonly performed. Or you can do radical mastectomy, which nowadays nobody does. Okay. What is the difference between modified and radical mastectomy? So the most important difference in modified radical mastectomy is that in modified radical mastectomy, pectoralis major muscle is preserved. Why is it preserved? There are two reasons. One is that it is cosmetically and functionally better. And the second and most important reason is that oncological results are not compromised. We don't want to do something which looks nice, but ultimately it is of no use. Ultimately, the cancer keeps spreading. All right. So that is the reason why modified radical mastectomy is done. Nowadays, we do something called as breast conservative surgery. Again, why? For cosmetic reason. Here, that includes wide local excision and quadrantectomy. You remove only that much part and then you follow it up with radiotherapy. Remember, whenever you are doing breast conservative therapy, you have to give radiotherapy. There is no other option. If you cannot give radiotherapy, don't do breast conservative. Okay, so let us look at this. Let us look at the various types of mastectomy. We are going to see whether the breast is removed. So breast is by default going to be removed. That is why it is called mastectomy. Whether we are going to remove the nipple areola complex and whether we are going to remove a part of the skin. Okay, when I'm saying skin doesn't mean that all the entire skin is being removed. Only a part of the skin is being removed. All right. Then we will see whether we remove axillary lymph nodes and whether internal mammary lymph nodes are removed or not. All right. So if you talk about a simple mastectomy, which is also called as a total mastectomy, here we will only remove the breast, nipple areola complex and skin. We will not touch the lymph nodes, whichever lymph nodes. If we are talking about extended simple, you will remove the breast, nipple areola complex, part of the skin, along with level 1 lymph nodes. We all know what is level 1, level 2, level 3, right? Level 1 are those lymph nodes which are lateral to the pectoralis minor. Level 2 are the lymph nodes which are behind the pectoralis minor, and level 3 are medial. All right. This is the one which we need to study. This is modified radical mastectomy commonly performed. Here, what do we do? Nipple areola complex, breast, and part of skin. Some of the textbooks mention level 1 and 2, but we also remove level 3. Okay. Don't go into the controversy because in the exam they are not going to ask. All you need to know is that axillary lymph nodes are removed and nothing is done to the internal mammary. And radical mastectomy is a surgery where pectoralis major and minor are both removed. Don't bother about extended radical. For 50-60 years, nobody has done. But just for your knowledge, in extended radical, they used to also remove internal mammary nodes. Okay, nobody is going to ask you extended radical because for 50-60 years, nobody has bothered to do it. Even radical mastectomy nowadays, no one does. These are the various incisions for modified radical mastectomy. Most often we take the Stewart incision. Okay, most often we take the Stewart incision or the Orr's incision. All right, usually this is what is taken. Must have seen. This is the same thing, just a little better diagram. Now, which of the following are removed in not removed in modified radical mastectomy? All are removed except. So what is not removed? We studied that it is pectoralis major. That is the major thing that you should remember. Pectoralis major will not be removed. Okay. So actually I would have given you time to answer the question, but somehow I'm not even able to see you. And if you keep stopping, then this will go on for a long time. That is why I am answering these questions. Okay, I'm sorry. I should have waited for you to answer the questions, but I'm not able to see any of your communication. So when we usually take a class in Zoom, I wait for the students to answer. But today we are on Google Meet and I'm not able to see, and we are also slightly short of time. That's it. Now, what are the structures which we remove in modified radical mastectomy? Remember, you remove the breast, you remove the axillary fat fascia and lymph nodes. You remove a part of the skin with the nipple areola complex, part of the skin with nipple areola complex, and pectoralis minor muscle may or may not be removed. What do you mean by may or may not be removed? So there are various modifications. Okay, so if you see the Auchincloss modification, pectoralis minor is not removed. If you see the Patty modification, pectoralis minor is removed. And if you see the Scanlon modification, pectoralis minor is cut and suture. Cut and suture back. Now, do you need to remember these? Usually this question has not been asked, okay? But just for your information, I've put it over here. A question has never been asked about the variants of modified radical mastectomy, okay? But just for your information, I've put it. So these are the structures which are removed. Now, this is most important. This is an exam question which is very important. What are the structures that are preserved in cases of modified radical mastectomy? So first thing that will preserve is the muscle, which is the one which you will preserve, pectoralis major. Always, always preserve. Then you will preserve the axillary vessels, that is the axillary artery and the axillary vein you will preserve. All right. And then you will preserve certain nerves. Which nerves will you preserve? So you will preserve the nerve to the serratus anterior, and you will preserve the thoracodorsal nerve, that is the nerve to the latissimus dorsi. Okay, nerve to the latissimus dorsi. That you will preserve. These are the two nerves that you have to preserve. Okay, so this is an important question. You must know what is it that we are going to preserve. Muscle, that is pectoralis major. Never, never, never forget that pectoralis major is going to be preserved in MRA. What are the possible complications? So the most possible common complication is collection of serous fluid, that is seroma. Another thing is that if there is injury to the nerve to the serratus anterior, there will be something called as winging of scapula. So if you ask the person to put the hands out, scapula will come out like this. Okay, winging of scapula. Apart from that, of course, there can be lymphedema, wound injury. Now, lymphedema, if it is long standing, say for example more than 10 years or so, it can develop lymphangiosarcoma. Lymphangiosarcoma. Now this is called as Stewart-Treves syndrome. This is called as Stewart-Treves syndrome. All right. This is what you need to remember. Again, exam question. Again, exam question. Winging of scapula is another exam question, and most common, this is an exam question. Now, there is another thing called as breast conservative therapy, where the entire breast is not removed, and this is basically for maintaining cosmesis. and you have to give radiation therapy. You have no other option. When will you not do a breast conservative therapy? So the absolute contraindication is that if you remove a small part of the breast and the pathologist tells you that there are still cancer cells present in the margin, in that case, you will not do breast conservative because you cannot compromise on the margin. All right, so that is one thing. Secondly, if you have a condition where radiation cannot be given, previously radiation was already given, or if the person has some connective tissue disorder, you cannot give radiation, don't do breast conservative. If it's a multicentric tumor, there is no question of doing breast conservative because you cannot remove 2-3 quadrants and expect cosmesis. And if the lady is pregnant, the tumor is aggressive, don't try breast conservative. Relative contraindications is that if you cannot achieve a good cosmesis, because basically you are trying to do a cosmesis, right? So if it's a large breast, or if it's a small breast with a large tumor, or if it's a centrally located tumor where you will have to remove the nipple areola complex, you might not do breast conservative. The relative contraindication. And if it's a multifocal, okay, then you will think twice whether you want to do breast conservative or not. These are relative contraindications. Now, how do you deal with axillary lymph nodes? So if axillary lymph nodes, when you look at the axillary lymph nodes, there are two possibilities. One is that the axillary lymph nodes are enlarged. There is lymphadenopathy and there is involvement. So in that case, what you will do is lymph node dissection. Now, why am I telling you this? Because in MRM, we have already said that we are going to remove axillary lymph node. But if you are doing something apart from MRM, for example, if you are doing breast conservative surgery, that is the time when you are supposed to think about axillary lymph node. Okay, that is the time when you are supposed to think about axillary lymph nodes. If you are doing MRM, there is no question. You are not going to bother whether I am going to keep axillary lymph nodes or not. You are going to remove it. But if you are doing a breast conservative surgery and if the axillary lymph nodes are involved, do the dissection, remove it. Now, what if the axillary lymph nodes are not involved? What if the axillary lymph nodes are not involved? In that case, you will do something which is called as sentinel node biopsy. What do we mean by sentinel node? Sentinel node is the first lymph node to which the tumor cells go or the lymph goes. It's the first cell to which the lymph goes. Okay, it's the first cell to which the lymph goes. Now, what is the importance? See, we know that in breast, axillary lymph nodes are the ones where the lymph goes first. But out of axillary lymph nodes also, which is that one which has the first lymph going? That is sentinel node. Now, what is the importance? The importance is very simple. That if the tumor cells have reached the sentinel nodes, then we assume that all the other nodes are involved and we will do lymph node dissection. But if the cells have not reached the first node itself, then we assume that the other nodes are also not involved and we will not do anything to the axilla. Now you will ask me, what is the big deal? Axilla operate to karne ka hai. You can always do that. Why do you have to bother whether it's involved or not? So the thing is that axillary dissection is a morbid thing. Okay, you are removing all the lymph nodes. There's chance of lymphedema, chance of infection, chance of seroma. So if there is no involvement, you can always avoid it. That's the reason. Okay, so sentinel node biopsy is the lymph node to which the first lymph node to which the lymph goes. Now, how do I find out? So I inject a dye in the tumor, okay, before I start the surgery. And within 10-15 minutes, I open the axilla and see which lymph node has taken that dye. In the next 10-15 minutes, whichever lymph node has taken that dye, that is likely to be the first lymph node. I will remove that lymph node and give it to the pathologist. And the pathologist will nicely see it with multiple slides and tell me whether there is any involvement or not. Okay. So, sentinel node is the first lymph node to receive the lymphatic drainage, and the dye that is used is either isosulfan blue, or if you have the facility of a Geiger counter. Geiger counter is the one which tells you about radioactivity. Then you can use technetium radio labeled sulfur chloride. So depending upon what you have, you can inject the dye, and within some time, when you take a biopsy, the first lymph node to which this goes, that will be stained. You give it to the pathologist. Nicely, the pathologist will take multiple sections and tell you whether there is involvement or not. If there is involvement, you remove the other axillary nodes also. Now, question is, what is the indications for radiotherapy? If it's a large tumor, more than 5 centimeters, more than 4 lymph nodes are positive. If you have done a surgery, okay, if you have done a surgery like this, okay, and you have removed the tumor, and if the tumor cells are over here, the pathologist tells you that, you know what, your margins are positive. The pathologist tells you that the margins are positive, cut margins are positive. Now you have to give radiotherapy. Or if the histological grade is high, I told you, modified tumor resection score. If the grade is high, then you have to give radiotherapy. If there are lymphovascular emboli inside the lymph or inside the blood vessels, if you see the cells, emboli of the cells, then you have to give. And if you are doing a breast conservative surgery, you have to give radiotherapy. There's no other option. Chemotherapy, what are the types of chemotherapy? So you did a surgery, and after the surgery, you found out that the tumor was more than 1 centimeter in diameter, or the tumor was more than 5 centimeter in diameter, plus it had some adverse features on pathology. Then you will give chemotherapy. So when you give chemotherapy after doing surgery, it is called as adjuvant chemotherapy. Okay, adjuvant chemotherapy. Now let us look at another patient who came to you. Now this person has a breast cancer, but you look at that person and say, if this cancer was slightly smaller, I would have been able to do a nice surgery. Or if it's a triple negative cancer, then you would say that, I'd rather reduce this cancer by giving chemotherapy and then I will do surgery. So in that case, you give chemotherapy and then you do surgery. So when you give chemotherapy before surgery, you call it as a neoadjuvant chemotherapy. And the third type of patient is a patient who comes to you, you do sonography, you do other tests, and you find that it is metastasized everywhere. Now you cannot cure the cancer, but you can just slightly decrease the problems associated with it. This is called as palliative chemotherapy. The goal is not to cure the cancer, but to just make the lifestyle a little better, quality of life a little better. There has to be a hormonal therapy slide over here. I think it just got. When will you give hormonal therapy? When ERPR receptors are positive. So what all hormonal therapy can you give? You can give selective estrogen receptor modulators. Now what they do is that they will modify the estrogen. Now there are two important ones that we can give. One is tamoxifen and other one is the raloxifene. Now at the level of breast, both of them are going to act as anti-estrogen. So they are going to stop any recurrence of breast cancer. At the level of the bone, they are going to act like pro-estrogen. That means they are going to prevent osteoporosis. So this is also good. This is also good. It is going to prevent breast cancer also. It's going to prevent osteoporosis also. But when they come to endometrium, now their actions differ. Here, this tamoxifen is pro-estrogen, and hence it increases the risk for endometrial CA. Whereas raloxifene is anti-estrogen, so here also Yeah, here also. The other two is aromatase inhibitors and SCRD, selective estrogen receptor degraders. Okay, the example is fulvestrant. The example is hexamastine, okay, and letrozole. And last slide is about monoclonal antibodies, where you can give trastuzumab or pertuzumab, that is for HER2. You can give lapatinib for other domains of HER2, and palbociclib and ribociclib for CDK. Okay, so these are the things that you can give for. All right. So this is all that we had. Over to Bharti, madam.
Thank you, sir, for this informative session, and we would appreciate if anyone has any question. If my screen is visible.
Yes, visible, ma'am.
Just a second. So rest of the students, if you have any questions related to the topic, what have been just covered, you're more than welcome. Okay, so thank you, Dr. Ahmed, for this very informative session, and I'm sure the FMG students will definitely be benefited with this session, and they will definitely perform good in their session. And just to conclude, I would like to update you all that Academically has come up with EduCafe. This is if you wish to study abroad. So we have this platform. And apart from that, as I said, we are coming up with the meet and greet sessions. As along with that, we have recently opened an experiential center in Hyderabad. It's just an add-on information for all those who have joined. And you can join our WhatsApp channel. The QR code is showing on your screen. And again, I would like to update you all that we have.
Ma'am, your screen is not fully shared actually. It's not on present mode.
Wait. It's better?
Yes, thank you.
Thank you, Faiz. So again, let me update you, like we have a WhatsApp channel as well. And I want to remind you all here that all those who have joined for the session, in your chat box, we have shared the link, and we are providing you with AI generated mock that will definitely help you for your FMG exam. And as I updated you, like we are coming up with meet and greet sessions, so you can take the full advantage of that as well. On the coming 27th of July, it's in Dehradun, followed by Hyderabad on 2nd of August, and then 3rd of August again. So do join us, and I believe the session was helpful for all of you. So Faiz, can we just wrap up here, or we wish to?
No, we'll wrap up.
Okay, great. So thank you, everyone. Thanks for joining with us. Thank you, Dr. Amit, for this informative session. Thank you, Dr. Akram. And thank you, everyone. And wish you all the very best. Again, just do your best, and rest is let's wait for the best results. Thank you.